Right, exactly. Or
Yeah.
like that container of leftovers in the back of the fridge that's become a whole science project.
Yeah, that fuzzy, forgotten science project. It's always something visible, something manageable.
Manageable, that's the word. Or maybe, athlete's foot if you forgot your flip-flops at the gym. It's an annoyance. It's definitely not something you lose sleep over.
Right. We sort of put them in a box. In our heads, they're decomposers, or they're food, or they're just a nuisance. We almost never think of them as, like, predators.
But that is exactly why we're here today. We are going to completely shatter that illusion. We're digging into a stack of medical research, focusing specifically on Chapter 38 of this massive infectious disease text, and it paints a much, much more alarming picture.
A completely different world.
We are talking about invasive fungal infections. And these aren't just rashes. These are organisms that are living in the soil, in the dust, sometimes even inside our own bodies, just waiting.
Waiting for an opportunity.
Yeah.
For a slip up in our defenses to turn from, a harmless neighbor into a life-threatening invader.
It's a huge shift in perspective, and our mission today is to unpack the big six. These are the fungal threats that infectious disease doctors actually worry about.
The ones that keep them up at night.
Yeah.
I'm talking about histoplasmosis, blastomycosis, coccidioidomycosis,
Cryptococcus, Candida, and Aspergillus.
the whole rogues gallery.
And for you listening, this isn't just some dry medical lecture. This is about understanding the hidden biological map of the country you might live in. It's about the fragility of our immune system.
And the sheer detective work it takes to diagnose these things. Because, and this is a theme we're going to see over and over, they are masters of disguise.
The great mimics.
Exactly. They fool us constantly. They can look like cancer. They can look like the flu. They can look like a simple bacterial pneumonia.
Okay, so let's start with that map you mentioned. I was really surprised by this idea that where you live determines what you breathe and, what might be trying to kill you. Can you just catch these things anywhere? Or is it really location, location, location?
Oh, it is absolutely about location. For several of these big ones, geography is destiny. They're environmental molds. They exist in very specific ecosystems in the soil, and they're often enriched by things like, say, bird or bat droppings.
Okay.
And the first one on our list, histoplasmosis, is just a perfect example of this geographic specificity.
All right, so let's unpack histo. If I'm looking at a map of the U.S. and I want to know my risk, where's the danger zone?
You want to look right down the middle of the country. The source material is really specific about this. It's the Ohio and Mississippi River valleys.
Wow, okay. So we're talking about a huge swath of the U.S.
A massive area. And if you live there, or honestly, even if you've just visited and, breathed the air on a windy day near a construction site or in an old barn, you've likely encountered Histoplasma capsulatum.
That is a really sobering thought. I mean, millions and millions of people live in those valleys. And the transmission is just breathing. We're not talking about touching some weird mushroom in the woods.
Nope. It's simple inhalation. We call them dust-borne microcanidia.
Okay.
Which is just a fancy way of saying microscopic spores that float in the air. You breathe them in, they settle into your lungs, and that's where the battle begins.
So if people in the Ohio River Valley are breathing this in all the time, which it sounds like they are, why isn't everyone in Ohio in the hospital? Why aren't we hearing about this constantly?
That's the amazing thing about our immune system, right? When it's working properly, it's incredibly efficient. So for the vast majority of people, people with healthy, robust immune systems, a low inoculum exposure.
Meaning you just breathed in a little bit of dust.
Exactly. You just walked past a dusty field. That results in either no symptoms at all or a really mild pulmonary thing. You might cough for a few days, feel a little off, but it's benign. It goes away on its own in a few weeks. The body just handles it, it walls it off, and you move on with your life.
Okay, so that's the best case scenario. But what if the dose is higher? Let's say you're tearing down an old chicken coop, which I know is a classic risk factor because of the droppings, and you get a face full of dust.
But that changes the whole equation.
Yeah.
If you're exposed to a high inoculum, even a perfectly healthy person can get hit really hard. Now we're talking about an acute flu-like illness.
So like fever, chills.
Fever, shaking chills, a pounding headache, muscle pain, what we call myalgia, and this dry, non-productive cough. It feels exactly like a terrible case of the flu.
But flu medication isn't going to help.
Not at all. Because it's fungal. Standard antivirals won't touch it.
And the text also mentions something about structural lung issues. This part felt really unfair to me. Like if your lungs are already damaged, the fungus takes advantage of that.
It absolutely does. This is where it gets more complicated. In patients who have emphysema, for instance, Their lungs have these little air pockets or bullae. They're structural abnormalities.
Right.
Well, the fungus sees those pre-existing spaces as a perfect playground. It sets up shop. This then becomes what we call chronic pulmonary histoplasmosis.
And what does that do to the lungs?
It usually settles in the very top of the lungs, the apical lesions. It causes inflammation, it can create cavities, and it forms these things called calcified granulomas.
Calcified granulomas, that sounds pretty intense. What exactly is a granuloma in this context?
Think of it like a little prison cell that your body builds.
Uh,
The immune system knows it can't kill the invader right away, so it tries to wall it off with layers and layers of cells. Eventually, calcium and scar tissue get laid down. It's a containment strategy.
But it doesn't always work.
In these chronic cases, it progresses over years. It can slowly destroy lung tissue, leading to pulmonary insufficiency. Basically, your lungs just stop working well enough to oxygenate you. And yeah, it could be fatal if it's not managed.
But the scariest category listed here by far is disseminated disease. That word disseminated in medicine, it's never a good sign.
It is, without a doubt, the nightmare scenario.
Yeah.
Disseminated histoplasmosis is when the fungus breaks out of the lungs. It escapes that prison, it gets into the bloodstream, and it goes everywhere.
Everywhere.
Everywhere. It targets the liver, the spleen, the lymph nodes, and even the bone marrow.
And who is at risk for this? Because a healthy immune system stops it at the lungs, right?
That's right. Dissemination targets the vulnerable. It attacks people who can't build that wall. So we're talking about infants, the elderly, and specifically immunocompromised people, like patients with AIDS.
And the mortality rate.
The source is incredibly stark about this.
Wow.
In infants, untreated disseminated histoplasmosis is nearly 100% fatal.
100%.
Right.
That is just terrifying, from breathing in dust.
It is. And in adults with AIDS, it presents in a very similar way, this acute, overwhelming syndrome. What's really chilling is that in an AIDS patient, this can happen from a primary infection, breathing it in right now.
Yeah.
It can be a reactivation of a dormant focus.
Wait, a reactivation, what does that mean?
It means you could have breathed in that spore 10, maybe 15 years ago when you were perfectly healthy. Your body walled it off, created that little granuloma, and it just sat there, alive, but dormant.
Like a sleeper agent.
Exactly. Then, years later, your immune system crashes because of HIV or maybe chemotherapy for cancer. The guard goes down, the prison wall crumbles, and the fungus wakes up.
That is a concept we are definitely going to come back to, that idea that your medical history is never really in the past. But for now, let's move the map. We're leaving the humid river valleys, and we're heading west to the desert.
Right. We are now moving to the lower Sonoran zone. So think of the semi-arid areas of the southwest U.S. We're talking California, Arizona, New Mexico, over to Texas. This is the home of mycoses.
Which is a complete mouthful, so I'm glad the text says we can call it Kochi or valley fever.
Yes, valley fever is the common name.
Yeah.
And it's distinct from histo, but the entry method is exactly the same. Inhalation of spores from disturbed dust.
And just like histo, most people don't even know they've had it.
That's right. About 60% of people who get infected are totally asymptomatic. Their immune system just handles it no problem.
And the other 40%, what do they experience?
They get pretty nonspecific respiratory symptoms. So fever, cough, fatigue, it could be 100 different things. But there's a visual clue here that can help doctors.
Oh.
A fine, diffuse rash can appear pretty early in the illness.
So if you've been hiking in Arizona, you come back with a cough and then you get a rash. Maybe you should think about fungus.
That is precisely the thought process. It's a key diagnostic clue. Now, the good news is that dissemination spreading to the rest of the body is really rare with Kochi, less than 1% of cases.
But when it does happen,
When it does, it's devastating. It can go to the skin, to the bones, and critically, to the meninges, the lining of the brain and spinal cord.
a central nervous system infection. That's always the big red alert in these texts, isn't it?
Always.
Yeah.
Fungal meningitis is just incredibly difficult to treat. The brain has this protective layer, the blood-brain barrier. It's great for keeping toxins out, but it also keeps a lot of our medications out.
So getting the drug to the bug is a massive challenge.
Huge challenge.
Okay, so we've covered the river valley fungus and the desert fungus. Now I want to move to the third member of this environmental trio, the one you called the Great Mimic. This section on blastomycosis really stood out to me because of how easily it seems to trick doctors.
Blastomyces dermatitis.
Yeah.
Yeah, this is another one you get from inhalation. The spores, the Candida, they go into the lungs and they transform into yeast. And you hit the nail on the head. It is a master of disguise. It mimics the things doctors see every single day, which is what leads to misdiagnosis.
The text says that acute cases look exactly like bacterial pneumonia.
Exactly. I mean, think about it from a doctor's perspective. In a clinic, a patient comes in, they have a productive cough. So they're coughing up pus, phlegm, they've got shaking chills, a fever.
Sounds like classic pneumonia.
It is. The doctor listens to the chest, hears that wet congestion, and thinks bacteria. It is the most logical first guess. So they prescribe antibiotics.
But antibiotics don't kill fungi.
Of course not. So the patient doesn't get better. In fact, they usually get worse. And they come back, and the doctor is stumped.
And what about the chronic cases?
This is where it gets even trickier and, honestly, more emotionally draining for the patient. Chronic blastomycosis looks remarkably like tuberculosis or even lung cancer.
Lung cancer, wow.
Yes, the patient has a low-grade fever, night sweats, they've lost a lot of weight. You get a chest x-ray, and you see a mass in the lung, you see a shadow. What is the first thing you're going to think?
Tumor. Malignancy. Absolutely. I mean,
Yeah.
imagine the emotional roller coaster of being told you might have lung cancer. You're preparing for chemotherapy. You're telling your family.
And then, weeks later, you find out it's a fungus you just happened to inhale.
Mm.
It happens more than you'd think. It's a huge relief, of course, but it just highlights how deceptive this organism is.
And it spreads, right? Unlike a simple pneumonia.
Oh, it has a nasty habit of spreading. The text says it can go to virtually every other body organ. Specifically, it loves the skin, the bones, the joints, and the genitourinary tract.
So if a doctor is really stumped, if it looks like cancer but the biopsy isn't cancer, and it acts like pneumonia but antibiotics aren't working, how do they finally figure this out? What's the giveaway?
You have to get a sample and look at it under a microscope. There is a very specific classic visual sign.
Okay.
When you look at the yeast in the sputum or a tissue sample, you see a large multinucleated yeast cell with a single broad-based bud.
A broad-based bud. Okay, help me visualize that.
All right, so imagine a snowman. Usually the head is attached to the body by a little pinch, a distinct neck, right? That's how a lot of yeasts look when they bud and replicate. But with blasto, the connection between the mother cell and the daughter cell is wide. It's a thick connection. It doesn't pinch in. That broad base is its fingerprint. If a pathologist sees that, they know instantly. It's blasto. Case closed.
I love that. It's like the fingerprint at the crime scene, that one detail that solves the whole mystery. Okay, let's move on to our fourth suspect. This one is described as ubiquitous and silent, Cryptococcus.
Cryptococcus neoformans. This is a yeast that's found in soil pretty much everywhere, all over the world. It's very often associated with pigeon droppings.
So urban environments, rural environments?
It's everywhere. And the text makes a really important point right away. It's non-contagious. You don't get this from another person. You get it from the environment.
Okay. And like the others, it starts in the lungs.
Yep. The primary infection is pulmonary. You get a cough, maybe some rales, which are these crackling sounds in the lungs, kind of like Velcro being pulled apart. But often it's very mild and resolves on its own. The lung infection isn't the main event for crypto.
The main event is when it spreads.
The main event is when it disseminates to the CNS.
We are back to the brain again.
We are. Cryptococcal meningitis is a major, major killer, particularly in the AIDS population. And this is where the listener needs to pay really close attention because the symptoms are totally different depending on your immune status. It's a crucial clinical distinction.
This part was fascinating to me. In a non-AIDS patient, so someone with a relatively intact immune system, the symptoms are what you'd typically expect for meningitis, right?
Correct. It's the classic presentation, a really stiff neck, what we call meningismus photophobia, which is extreme sensitivity to light, and changes in mental status, like confusion. You look at that patient and you know something is seriously wrong with their neurological system.
That stiffness is the body fighting back, basically.
Exactly. It's the inflammation from the immune response that causes all that pain and stiffness. But in an AIDS patient,
It's different.
it's completely different.
It's stealthy.
Because their immune system is so suppressed, they don't mount that massive inflammatory response.
No stiff neck.
Often, no. No stiff neck and no light sensitivity. They might just have a fever and a headache.
That's incredibly dangerous. A fever and a headache could be almost anything. It could be dehydration, the flu, stress.
Absolutely. It makes it so much harder to spot clinically.
Yeah.
You have to have a very high index of suspicion. If an AIDS patient comes in with a persistent headache, you have to be thinking about this.
And how do you diagnose it, for
You
sure?
have to do a lumbar puncture, a spinal tap. You'll see the pressure of the fluid is elevated, the protein is high. And then there's this classic, almost old school test they mention the India ink smear.
I remember that from art class. Blacking.
The very same. You take the cerebrospinal fluid from the tap and you mix it with a drop of India ink.
Mm.
The Cryptococcus yeast has this thick, gelatinous capsule, a protective shield around it.
Okay.
And that capsule repels the ink particles. So under the microscope, the ink creates this black background, but the yeast shows up as these glowing, clear halos against the darkness. It's positive in about 60% of patients.
That is such a vivid image. Halos in the darkness. It sounds almost beautiful if it weren't so deadly.
It is hauntingly beautiful, but it signifies a very severe infection.
No, we need to pivot. A big pivot. Everything we've discussed so far, histo, kochi, blasto, crypto, these are invaders from the outside world, things we inhale from the soil or the air. But this one is already inside us.
Candida.
The enemy within.
Literally. Candida is a normal resident of our gastrointestinal tract. It lives in our gut. We coexist with it, and most of the time, it's a perfectly peaceful neighbor. But it's an opportunist. It just waits for the host to become vulnerable.
And we're not just talking about like thrush or a simple yeast infection, which are superficial. The text talks about hematogenous candidiasis.
Right. Hematogenous just means blood-borne. We're talking about the fungus breaking out of the gut or maybe getting in through the skin and entering the bloodstream. And once it's on that highway, it can see deep organs, the eye, the brain, the heart, the kidneys.
So if it's normal to have it in our gut, what changes? What lets it go rogue like that?
Usually it's our own medical interventions or a severe illness. The text lists the risk factors, and it's a list of things you see in a modern hospital. Central venous catheters.
The tubes that go into the big veins near the heart?
Right. They're a direct highway for the fungus to get past the skin barrier. Then there's total parenteral nutrition 4V feeding, which is full of sugars and lipids that fungi just love to eat. Renal failure is another risk. Extensive burns, which destroy the skin barrier.
And ironically, antibiotics.
Yes. This is one of the great paradoxes of modern medicine. We give these powerful, broad-spectrum antibiotics to kill off a bacterial infection. But those antibiotics also kill all the good cops in your gut, the beneficial bacteria that normally keep Candida in check.
They compete for space.
They compete for space and food.
Go.
So once you nuke the bacterial competition, Candida has a party. It overgrows, it riots, and it can break right through the gut wall.
The diagnostic challenge here seems really frustrating. If it's in the blood, shouldn't a simple blood test just find it?
You would absolutely think so. And that's what's so frustrating for doctors. The sources say that blood cultures, they're only positive in like 25 to maybe 45% of patients.
Wait, so less than half the time?
Yeah. Less than half. It means you can have a raging systemic fungal infection, and the main test you'd use comes back negative, more than half the time.
That is a massive blind spot. So doctors are often flying blind, just treating based on suspicion.
Often, yes.
Yeah.
If a patient in the ICU has the risk factors, the catheters, the antibiotics, and they have a fever that isn't responding to more antibiotics, you have to assume it's fungal. You have to treat the ghost in the machine because you can't wait for a positive test that might never, ever come.
Okay, on to our final member of the Big Six. We're back to molds, and this one is arguably the most common of all. If you leave bread out on the counter, you're going to see this. Aspergillus.
Aspergillus. It is everywhere. There are over 300 species, but A. fumigatus is the main bad guy for humans. We are inhaling these spores constantly. You and I are probably inhaling them right now.
That's a comforting thought.
It is, but what's really unique about Aspergillus, and what the listener really needs to grasp, is that it can present in 3 completely different ways, depending on how your body reacts to it. I like to think of it as the good, the bad, and the ugly, though good is a very relative term here.
Okay, let's break those down. Presentation number 1, the allergic reaction.
This is called allergic bronchopulmonary aspergillosis. It's not really an infection where the fungus is eating you. It's your immune system freaking out about its presence. It mimics severe asthma. You get terrible wheezing, fever, and you can cough up blood-streaked sputum.
So the treatment isn't just about killing the fungus.
No, because the damage is coming from your own immune response, so you have to treat it with corticosteroids to calm the immune system down, in addition to antifungals to knock back the amount of mold. It's a real balancing act.
Okay, presentation 2. This one has the absolute grossest name, and frankly, the grossest concept, the fungus ball.
The aspergilloma. This happens when the fungus decides to colonize a pre-existing cavity in the lung. So let's say you had tuberculosis years ago and it left a scar, a hole.
Yeah.
You have sarcoidosis.
Right.
Aspergillus finds that nice, quiet, protected hole, and it just It grows a solid ball of fungal matter inside it.
It just sits there, a ball of mold inside your lung.
For the most part, yeah. It's what we call saprophytic colonization.
Yeah.
It's living off dead tissue and debris. It's not actively attacking living tissue, but it's taking up space.
Yeah.
And it can erode the walls of that cavity and cause really significant bleeding hemoptysis.
And you can't treat it with drugs.
Not really. The drugs can't penetrate that dense ball well enough to kill it. The only real fix is surgery. You have to physically go in and cut the ball out.
And finally, presentation number 3, the ugly.
The ugly and most deadly. This is invasive aspergillosis. This happens in severely immunocompromised hosts, bone marrow transplant patients, people with prolonged neutropenia, which means they have almost no white blood cells. In this case, the fungus doesn't just sit in the cavity. It invades. Specifically, it invades blood vessels.
Vascular invasion. That sounds incredibly aggressive.
It's the definition of aggressive. It literally grows through the vessel walls. This causes thrombosis, blood clots. It cuts off the blood supply, which causes infarction tissue death, and then necrosis. The tissue literally rots because the fungus has choked off its circulation.
The text mentions a really specific and frankly gruesome symptom here, an eschar.
Yes. An eschar is essentially a scab of dead tissue. It's usually black. And with invasive aspergillosis, you might see a black eschar forming over the nose or in the sinuses or on the palate, the roof of the mouth.
Wow, so that's not just a sore, that's the actual tissue dying.
It's the tissue dying because the fungus has strangled its blood supply from the inside out. It's a sign of incredibly rapid destructive invasion.
And on an x-ray, what does that look like?
You see something called a wedge-shaped infiltrate. Think of a slice of pie. That wedge shape points to where the blood vessel was blocked and everything downstream. The wide part of the wedge is the area of dead lung tissue. It's a very distinct, very ominous sign for radiologists to see.
Okay, so we've met the big six. We know how they attack. Now we have to talk about the arsenal. How do we fight back? Because reading this section, it feels like the weapons we have are, well, they're heavy. They're not precision strikes.
That's a great way to put it. Treating fungi is so much harder than treating bacteria. You have to remember, biologically, fungi are eukaryotes. Their cells are structured very similarly to our human cells.
Right.
Bacteria are prokaryotes. They're very different. So it's easy to find a poison that kills bacteria but ignores our cells. But anything that kills a fungus has the potential to hurt the human host too, because our cellular machinery is so similar.
It's hard to find a poison that kills them but spares us.
Exactly. Which brings us to the drug with the heaviest reputation of all, amphotericin B.
The heavy artillery.
That's what it is. Doctors sometimes joke and call it amphoterrible because of the side effects. It's been around for a long, long time, and despite those side effects, it is still used for the most severe, life-threatening diseases. Disseminated histo, severe blasto, cryptococcal meningitis.
When you have to kill it now.
When you have to kill the fungus now or the patient's going to die, you bring out the amphotericin.
So what's the catch? Why the terrible nickname?
Renal toxicity. It damages the kidneys. It's almost guaranteed. It constricts the blood vessels going to the kidneys, and it directly damages the kidney cells.
Oof.
We try to mitigate this now with lipid formulations, basically wrapping the drug molecule in fat to protect the kidneys. But it's still a very toxic drug. It often causes shaking, chills, high fever, and nausea right when you infuse it. It is a rough ride for the patient.
And it's given intravenously, I assume.
Intravenously.
Yeah.
You have to be in the hospital. And in the most desperate cases of meningitis, sometimes it's given intrathecally.
Which means?
Injected directly into the spinal fluid.
Wow. That is intense. Okay, so that's the nuclear option. What about the infantry? The drugs that are a bit more manageable?
That would be the azole class of drugs. Itraconazole, fluconazole, voriconazole. These are much better tolerated. They often come as oral pills, and they work by messing with the synthesis of the fungal cell membrane.
Let's break them down quickly so the listener knows the difference. Itraconazole.
Itraconazole is the workhorse. It's used for mild to moderate histo and blasto. It's also very often used as step-down therapy. You hit the patient hard with IV amphotericin B first to save their life, and then you switch them to oral itraconazole for months to finish the job.
Okay.
The one key with ITRA is that absorption can be tricky, so you have to monitor the levels in the blood to make sure the patient is actually getting enough of the drug.
And fluconazole?
That's the brain specialist. It gets into the central nervous system very, very well. So it's key for things like cryptococcal meningitis and coccidioidal meningitis. It's also the go-to for many Candida infections. It's probably the one most people might have actually heard of.
And the last one, voriconazole.
Vori is the specialist for Aspergillus. The text specifically highlights it as the drug of choice for invasive aspergillosis. There were studies that showed it actually has better survival rates than even amphotericin B for that disease.
But it has its own quirks, right?
It does. It can cause visual disturbances. People report seeing flashing lights or wavy lines shortly after they take a dose. It's usually temporary, but it can be pretty disconcerting.
I'll bet. Okay, there's one more class mentioned, the echinocandins.
Right, these are newer. They work on a totally different target, the fungal cell wall, specifically a component called beta-glucan. And since human cells don't have cell walls, these drugs are incredibly safe for us. They're excellent alternatives for Candida, especially for species that might be resistant to the older drugs, very well tolerated.
Now, there's a concept in this treatment section that really struck me, and it sort of brings us full circle to the severity of these infections. The idea of suppressive therapy, it almost sounds like admitting defeat.
It's not so much defeat as it is a stalemate, a negotiated peace. In patients with AIDS or other people whose immune systems are permanently compromised, you often can't cure the infection in the traditional sense. You can't eradicate every single fungal cell because the body can't help you with that final mop-up operation.
And the relapse rates are huge.
They're astronomical. The text says 50 to 90% for histoplasmosis in AIDS patients if you stop treatment. It just comes roaring back.
So what do you do?
You put them on lifelong suppressive therapy, usually a daily dose of an oral azole, like fluconazole. You're essentially just keeping the fungus dormant, pushing it down every single day so it can't rise up and cause disease again.
That is such a heavy burden for a patient, to
Right.
know you have to take a pill every single day just to keep that sleeper agent asleep.
It is, but it keeps them alive. It turns what was a fatal disease into a manageable chronic condition, much like how we treat HIV itself now.
So we've unpacked a lot here. We've gone from the river valleys to the desert, from pigeon droppings to the lining of our own gut. We've talked about fungus balls and amphoterrible. What's the big takeaway here?
I think the synthesis is really about complexity and vigilance. Fungal infections aren't just one thing. They can mimic cancer. They can look like the flu. They can show up as a rash or a brain infection. They are incredibly versatile. They're survivors.
And for the listener, why should they care about this deep dive? What's the so what?
Because it highlights the really delicate balance of our own existence. For most of us, the immunocompetent, these organisms are often just minor blips. We breathe them in, our immune system walls them off, end of story. We don't even know a war was fought.
But for the immunocompromised.
But for the immunocompromised, and that population is growing, with more transplants, more chemotherapy, better HIV care, these organisms are lethal adversaries. It changes how you have to look at medicine. It's not just about the bug anymore. It's about the host.
And that leads me right to the final thought I want to leave everyone with. The text kept mentioning dormant foci with histoplasmosis, this idea that you can get infected, get better, and think you're totally fine. But the fungus is still there.
It's just waiting.
Exactly. And it leaves you with this really provocative thought. Even if you are perfectly healthy right now, an exposure from a camping trip you took 20 years ago could have left a sleeper agent in your body. It's just sitting there, walled off, waiting for your immune system to slip up, maybe decades from now.
It forces you to realize that our history, where we've lived, where we've traveled, it's written into our biology. Sometimes in ways we can't see until it's too late. It's a powerful reminder that we are part of the ecosystem, not separate from it.
On that incredibly cheerful note, thank you for joining us on this deep dive into the fungal kingdom. It is a wild world out there, and apparently in here as well. Stay curious and maybe wear a mask if you're cleaning out an old chicken coop.
That's very sound advice.
See you next time.